Hello, everyone. Hi. Nice to meet all of you in Madurai. I'm really happy to see all of you here. I was unable to come physically, but virtually I'm with you. And I thank the President, Secretary, the office bearers. Congratulations for hosting Dr. Usha SARAIYA 2024 Oration in this beautiful temple city of Tamil Nadu in Madurai on 25th of May 2025 at the 31st annual conference. It is a great honor and privilege for me to be giving this Dr. Usha SARAIYA oration amidst all of you, and I thank each one of you to be present today. I will now share my slides with all of you and start my oration. The topic of oration is Unraveling Malignancy Risks. It's a comparative analysis of 4 RMI indices for Adnexal mass assessment. I'm really honored to be in the city of Madurai, and I take the blessings from this beautiful Meenakshi temple here in your city. Thank you for inviting me today here. But before this, I would like to acknowledge the Foxy ICOG team 2024 who chose me as one of the participants and the final finalist to give this oration. And I would like to thank the president of 2024 Foxy, Dr. Jaideep Tank, and the ICOG team, Dr. Parul Kothadawala, Dr. Sheila Mane, Dr. Sarita Bhalerao, and of course, our dear Madam, Dr. Usha SARAIYA. I would also like to thank the whole Madurai Obstetric and Gynecological Society organizing team led by the president, Dr. M. Gayatri, secretary, Dr. S. Padma, the treasurer, Dr. S.S. Gayatri, and the patrons, Minambal and Dr. Revati Janaki Ram. I'm really happy to be getting this oration presented in front of you. Thank you, Dr. Padma, for being in touch with me for so many months. I would also like to thank the chairpersons, Dr. Lalita S., Dr. Revati Kailarajan S., and Dr. C. Shanti to be chairing this ICOG Dr. Usha SARAIYA oration. Perfection is not attainable, but if we chase perfection, we can catch excellence, as said by Vince Lombardi. I bring greetings from my hospital, popularly known as Sion Hospital in the city of Mumbai, where I have been a professor and I started my residency in 1991, spending 34 years of my life in this great hospital which caters to the largest slum area of Asia, popularly known as Dharavi. And it's really great to serve those patients who are coming from poor society, middle class society around the vicinity of this hospital. Let me introduce you what is the topic of this whole uh, oration which I'm giving. We are talking about adnexal masses. The adnexal mass is basically an ovary, the fallopian tubes, the pelvic organs within. On the lateral border is the pelvic brim. Below is the pouch of the Douglas. Above left side, you have the round ligament, and medially the posterior surface of the uterus. So as per the International Ovarian Tumor Analysis definition, we are dealing with a lesion which is inconsistent to the normal physiological function. And that's how on ultrasound we define as an adnexal lesion. It could be a benign, it could be a malignant lesion. So we are dealing here with premenopausal and postmenopausal women. And as you are aware, these adnexal masses could be cystic, could be solid, cystic solid combination, simple or complex, unilateral or bilateral, which could be as an ectopic pregnancy, an ovarian tumor, a polycystic ovaries, abscesses, tuberculosis of the ovary. And of course, we have fibroids, a broad ligament fibroid being sitting there, or a fibroid which is true or false, or it could be a malignant ovarian tumor in a postmenopausal woman. So all this consists of adnexal masses, and it's commonly found in our examination when we do the abdominal examination, the per vaginal examination. These two fingers are the eyes, what we have as a gynecologist. And when you do a bimanual examination and press from above the adnexal mass, the fornix, you will come to know what are we dealing with. And then we further go with an ultrasound, a color Doppler, and further high imaging studies if required. Well, some of them are absolutely asymptomatic and you find big masses, or some of them are very symptomatic and you will find a small malignant mass. So it's very different, and pain could be a feature, tenderness could be there. It could be because of a rupture, because of a torsion which you find, or a bleeding inside, a venous stasis, and all these things can be seen. Well, but the general statistics, what they say is that if you have malignancy, unfortunately, it can occur in 24% of premenopausal and 64% of postmenopausal women. And here now, after the general examination, the abdominal and the pelvic examination, you have a beautiful ultrasound which comes to your help. It could be a transvaginal ultrasound, a transabdominal ultrasound, and there we have the risk of malignancy index. I'll go in the deeper aspect of RMI index. Well, this is a combination of demography, of ultrasonography, and biochemical data, which was first reported by Jacobs et al. You can see the slide here on the left hand side shows multilocular cyst, a cyst which has a solid component, ascites. It could be a unilateral or a bilateral lesion, or an intra-abdominal metastasis, which you can see a beautiful ultrasound pictures. And if you see the slide now on the left hand side, you have RMI1, RMI2, RMI3, and RMI4. Those are by Jacobs et al., Tinglestad et al., 1990, 1996. Further, he has done RMI3, where there are changes in the postmenopausal state score, and the Yamamoto et al. In 2009. But first, let us understand the three parameters. The first one is ultrasound score, which is defined into U, and it is divided into no feature, one feature, or more or equal to two features, given the scoring as 0, 1, 3, and further in RMI 2 and 3, 4 differently. In menopausal score, we have premenopausal state, which is given as M equal to 1. And if it is postmenopausal state, it is 3 in RMI 1, 4 in RMI 2, RMI 3, 3, and RMI 4. I will describe it later further. And CA125 value is taken as an actual value, and that is further multiplied with UM and the CA125 value. But in RMI 1, 4 of Yamamoto 2009, he added the size of the mass, which is less than 7 centimeter equal to 1, and more than or equal to 7 centimeter as 2. So when you're dealing with all this RMI index, it is much simpler and much better, especially in secondary and a primary health center where we do not have CT, MRI, and PET scan. And that is the advantage for all of us to detect adnexal masses with malignancy. And that will help us to differentiate between benign and malignant lesions. So, well, this study was done for 20 months. And it was a cross-sectional observational study done in my unit, NNC unit, Dr. NNC, and all the patients followed up in OPD in the tertiary care hospital. And the sample size we got was 75, and the subjects cases were from the age group of 18 years of age till 75 years, and they were willing to undergo the consent and the surgery if required, either by laparoscopy or by laparotomy. So we had all these imaging modalities available with us, and clinically confirmation of the women which came in adolescent, reproductive, pre and postmenopausal groups, and they were willing for laparoscopy, laparotomy, and then a final diagnosis of histopathological correlation was also done. So we had ovarian masses which were excluded with clear cyst, which were small in size, or women with adnexal masses which were not fit. They were high risk for any surgery management, and non-gynecological origin, they were excluded. Well, some of the patients which were already diagnosed with malignancy were excluded, or incomplete medical record, or those who could not follow up later, non-compliant patients, patients who underwent second look laparotomy from the previous treatment and not willing to participate. So we had this exclusion criteria, and the 75 members were chosen. And as I said, this took place in our my unit, single unit, for 2 years. And we obtained all the data. There was a questionnaire which was given to them, and all the data was filled up, which included the age of the patient, the demography from which area she comes, age of menarche, the menstrual cycle regularity, when she attained, if she was menopausal, the menopausal age, if she had undergone any hysterectomy or hysterectomy which was done more than 1 year of amenorrhea, what was her age, less than 30, more than 50, postmenopausal, perimenopausal, and an ultrasound which was done to assess the adnexal mass, and we had that score being ready. MRI was done in some of the select cases where we suspected they need further evaluation of benign or malignancy. And of course, the CA125 and RMI scores were recorded, surgical details and histopathology confirmed the final diagnosis. So, the scoring system, as I said, now we start Jacobs et al. 1990. We have the criteria, as I mentioned, which include the menopausal status, 1 and 3 score, ultrasonic features, 4 of them, whether it was multiloculated and solid areas were there, or there was bilaterality, ascites, metastasis, and accordingly, any of this feature was present. One of them was 1, no feature 0, and more than 1, 3. And then serum CA125 absolute level. And then the risk of malignancy index was calculated, A multiplied by B multiplied by C. Then we have RMI2, that is Stingel-Stud et al. In 1996, U multiplied by M into CA125, and the scores were, as I have explained here in the previous slide. And then we had RMI3, Stingel-Stud et al. 1994. Here the changes were in the score of more than 2 in U equal to 3, and postmenopausal M equal to 3, and premenopausal M equal to 1, and Yamamoto, where apart from this, the postmenopausal status M was equal to 4. And here the tumor size was taken into consideration, less than 7 centimeters, S equal to 1, and more or equal to 7 centimeter made as S equal to 2. And then the CA125 was applied directly to the calculation. So with all this scoring done, we come to the results of our study, where out of the 75 cases, 63 were benign and 12 were malignant masses. And I will revert back to the table 1, which is there, and it showed 53% of malignant cases, that is serous cyst adenocarcinoma, while serous cyst adenoma, you can see the wonderful pictures here, which we have got, 23.8%, that is serous cyst adenoma. And here, cyst adenocarcinoma was 58.3%, which was the common malignant table seen in table 1. So here is the further evaluation. As per the histopathological diagnosis, you find 63 benign masses, malignant masses 12, dysgerminoma, granulosa cell tumor, mucinous cyst adenocarcinoma, and serous adenocarcinoma. That is 7 of them, 58.33. If you see out of all the benign, serous cyst adenoma 15, that is 23.8 was seen. So all these benign and malignant cases were further distributed as per the age, the menopausal status, the family history of malignancy, tumor size, and serum CA125. And here we find in the table number 2 that about malignant cases, 58.33, that is 7 you find. And as per the age less than 30, we had benign, that is 29 cases, 36.5. Further distribution, you can see here the menopausal status, the premenopausal, postmenopausal, and family history. You find that there was no family history of malignancy in this 63 benign cases. And in 9, you can find that there was family history 75%. And of course, the CA125 level, which you can see here, less than 35, benign cases were 36. And however, less than 35, you find 25%, that is 3 cases having malignancy. And that is what we can see significant correlation here between the histopathology and the CA125, which is table number 3. As I said before, we find that histopathology, if you see less than 35, benign were 36, 27 were CA125, that is 63 of them. And in malignant, 3 of them, CA125 was less than 35, and 9, of course, they had a more than 35 level. And that's how the total of the cases you find 12 as malignancy. And here on the right hand side, you will see the CA125, the p-value, the sensitivity, specificity, the positive predictive value, and the negative predictive value, which you can see. So all these 4 RMI scores significantly had a correlation with histopathological diagnosis with a p of less than 0.001. And here you find this correlation of the RMI index 1, 2, 3, 4 with the histopathological diagnosis. Similar, if you compare 62, benign 59, 62, 61, and on malignancy 3 by 9, 3 by 9, 3 by 9, you can find where the RMI index is less than 203 malignant cases and more than 200, it is 9. And the predictive value is also less than 0.001. So this is one more thing. And the sensitivity, specificity, positive predictive value, negative predictive value is similar in all these RMI 1, 2, 3, 4, somewhere from 69 to 70, 71, specificity also from 90, 91, 92, and so forth you can find. Coming to the discussion in our study, as I said, 75 patients, 84 were benign, 16 were malignant adnexal lesions. And the similar findings were also noted in Akturk et al., where 80% were benign, 20% were malignant. This has been published in 2011 in the Journal of Gynecological Oncology, and Yamamoto et al., who has also published in European Journal of Obstet Gynecol. This is the comparative study, which is similar to our study. So in mean age in our study was 52 plus or minus 6 years, comparable to Yamamoto et al. And in premenopausal women were more likely to have benign lesions, that is 73.01%, while malignancies were more common in postmenopausal women. The tumor size, if you see, more than 7 centimeters was observed in 90.76% of benign, and 91.66% of malignant cases were consistent with Yamamoto et al. The CA125 level averaged for 145.91 international units per ml for malignant and 40.41 per ml for benign lesions, and which aligned with Zhang et al. Well, so as I said before, the RMI 1 and 4 sensitivities range from 69 to 76, and specificities from 90 to 92, and good significant correlation was there with histopathology with no major difference among them. So in conclusion, if you compare RMI 1, 2, 3, 4, all the four malignancy risk indices can precisely discriminate malignant and benign adnexal masses, and that is what we have found. So either you take one or you take four, they are similar to that extent to distinguish between malignant and benign adnexal diseases, and there was no statistical difference found. Well, so this is a very important message which I want to give you rather than going for a high color Doppler or for CT MRI. Of course, facilities are available, you can go ahead, but this scoring system is the most simplest one. It is a non-invasive one, easily accessible, can be done by our gynecologist, even in peripheral or secondary hospitals, and is favorable and affordable. And that is what has made a change in our obstetric and a gynecological practice which we are doing. It's a very important one, an appropriate management tool which can be then further applied, and prompt referral of patients then can be done to the tertiary center, especially when managing malignancy, where you have to have a joint multidisciplinary approach in managing such cases. Well, so I would like to end my talk. It's often the small steps which we take, not the giant leaps, that bring about the most lasting change. And I hope my oration talk on RMI indices is going to broaden your horizon of knowledge, and it's going to make a lot of difference in your practice from tomorrow onwards. Thank you so much for a patient hearing, and I would like to stop share my screen, and I'm really happy to be with all of you today. It's really great honor to be there, being there, sharing with you this plaque which has been given to me by the Indian College of Obstetrics and Gynecology. Well, Dr. Niranjan Chavan, Mumbai, professor and unit head at the Department of Obstetrics and Gynecology, LTMMC, LTMMGH, Sion Hospital, Mumbai. We are giving this ICOG Dr. Usha SARAIYA Oration 2024 for the scientific work in gynecologic oncology on 25th of May 2025, hosted by Madurai Society and signed by Dr. Jaideep Tank, the President Foxy, Dr. Parul Kothadawala, the ICOG chairperson, Dr. Sheila Mane, the vice chairperson, ICOG, Dr. Gayatri, President, MOGS, Dr. Padma S., Secretary, MOGS, and Dr. Sarita Bhalerao, Secretary of ICOG. I'm really grateful to all of you, and it's a great honor for me to be with all of you. Thank you so much for a patient hearing, and I'll surely catch up with you soon in one of the conferences. Take care. Bye. Have a great day. Thank you so much once again.